Hi everyone, welcome to the second episode of the University of Chichester Department of Psychology guest series. So today I'm really pleased to be joined by my good friend, Dr. Emily Sandoz, who is a professor of social sciences at the University of Louisiana at Lafayette, and who is also a private clinical psychologist. And today we're just going to discuss Emily's background, how she came into psychology, and discuss her clinical work, her underlying philosophy, her work with eating the disordered clients and issues around body image, and also her passion for women in science. So you are very welcome, Emily.
Thank you so much. I'm so glad to
Okay.
be here, Ian.
Yeah, it's very welcome. I was just going to start. Could you tell us a bit about who you are and your background and how you came into psychology?
Yeah, sure. I think I had kind of an interest in people for a long time. I think I had. I What I thought I was going to do, though, upon kind of completing high school and getting to the end of that, is I thought that I was going to be an actress. Now, what I loved about acting, though, which probably doesn't surprise folks who know me professionally, was the idea that I could sort of tell somebody's story in a way that somebody else could connect with really their own story. So
Yeah,
I could, by telling somebody else's story, help somebody, in this weird circumstance, in this dark room, maybe in this theater, could connect with things that maybe out in the world they don't really let themselves feel or let themselves think about. So I did lots of competitive drama and
yeah,
stuff, and really enjoyed that all through high school. And I thought that I was going to be an actress. And in my senior year of high school, so the very last year of high school, I had a sibling that died. My brother Danton died, and suddenly it didn't make a lot of sense to me to move away and to start doing something big. I kind of stopped and paused and went through school for a while in a way that wasn't particularly inspired or
yeah,
effective. I kind of went to the local school and kind of just didn't lose my scholarship, did what I needed to do
yeah,
to not lose my scholarship. And after about a year, I became pregnant with my daughter Hannah. And after having Hannah, decided to have her and to become a mom. And for me, my second year of college as a young mother and with this kind of grief at my back, it really didn't make sense for me to be in school if I wasn't doing something that really mattered. So I was kind of on the hunt.
yeah,
I was taking psychology classes and enjoyed that. I tried on pre-med for a little while. I tried on speech pathology and communicative disorders for a little while. My brother who died was deaf.
yeah,
And I finally settled on, somebody gave me a book actually on acceptance and commitment therapy. One of my professors, who is a behaviorist, gave me a book on acceptance and commitment therapy, and it all kind of made sense. By that time, I think I was a junior or senior in college, and actually the Twin Towers had just fallen. The World Trade Center had just been attacked on 9/11. My daughter was 2 at that time. And the first line in the book of acceptance and commitment therapy says something like, the most incredible fact of human existence is how hard it is for us to be happy.
yeah.
um, and suddenly everything kind of clicked into place. So I started studying behaviorism and seeing what I could get out of that, and trying to piece it together with ACT, which seemed really far away and different. And yeah, everything kind of fell from there. That's a lot of tragic stories I've
Stories,
just
yeah. So,
told.
at what age were you when Danton died? So you were only
So
in high school at the time, is it?
I was 17 years
Oh wow.
old, and he was 3 years younger than me. He was 14. So we had just started here. Our high school is from about age 14 to about age 18. So we had just started going to high school together,
Yeah, yeah,
and being in school together when that happened. And it was really stunning. He had been sick for some time. He had a heart condition that was associated with
yeah,
deafness, but not sick in a way that impacted him every day. So sick in a way that when we were very young, he would have frequent heart attacks. But at the time that he died, he hadn't had an episode or a heart attack in several years. So it was quite, when he was really little, we didn't expect him to live very long, but he kept living. So by the time we were in high school together, it was really, quite shocking. I guess it always is when a child dies.
And were you fully fluent in sign language when you're communicating with Danton? Yeah. So.
Yeah, I was actually. So because he was just 3 years younger than me, we sort of grew up together, and my mom became involved in deaf education. So she was in school when I was born, and when Danton was born, she was still in high school, in college herself, and she got her master's in deaf ed. And so, I was actually, as a child, she was learning sign language, and she did sign language interpreting, and she even put me in a reverse mainstreaming program. So, rather than deaf kids coming into hearing classrooms, I went to school at the deaf school for half a day and spent it immersed with deaf children. So we were quite involved in the deaf community as a child. Danton was profoundly deaf, so he wasn't able to hear at all. He only used ASL, American Sign Language. So we all used sign language in the home all through my life. In fact, after he died, I was still wanting to keep my sign language up, so I did a fair amount of sign language interpreting all through college, just kind of as for extra money and stuff.
It sounds amazingly progressive. That's something that we think we might be doing now in 2021, is like the half day in one school, a half day in the other. That's really progressive for that time, I think. It's
Well, Louisiana has a really high, I think it's just genetic. We have a really high prevalence of profound deafness. So there's many deaf people in southern Louisiana. And so Baton Rouge, where we lived at the time, had the Louisiana School for the Deaf. And so they had like quite progressive programming there. It's funny because thinking back, of course, to me, it just makes perfect sense. But these days I'll hear about children who are deaf children and hearing families who's no one in their family uses sign language. Maybe their parents do, or a parent does, but their siblings don't learn. We couldn't speak in the house. The rule was you couldn't speak in the home with Danton in the room. Sign. So we all use sign language all the time. I feel quite fortunate, kind of thinking back that was her attitude towards it.
Thanks. And so when you received this book from your professor on acceptance commitment therapy, and I know that line that you're mentioning as well, it's like everybody suffers, and you really have to think about it, and you're wondering, is that too big? Is that too big a claim? But when you start talking to people and you deal with people, certainly with clients at all, it definitely rings true. And I know that Steve Hayes used to always give the example of a childhood suicide to kind of make it all real, that if you can imagine a future that you haven't lived yet that's somehow better than the present that you're living in, then that shows how the powerful effects of language can work. And that's the kind of where acceptance commitment therapy kind of fits in. So can you tell me how you trained in acceptance and commitment therapy, and what your path was then?
Yeah, sure. Can I tell you one story? My example, I have my own kind of story, like Steve, example of how sort of, I guess, real and universal suffering is. My son, Julio, was probably, he must have been barely 3, and we had the labbies over at the end of the semester, my research students, and we were playing Dance Dance Revolution in one room and playing Rock Band, in the other room, and singing karaoke, and Julia was sort of running all around and singing and dancing with everyone, and really, really enjoying himself and just really kind of the center of attention and having fun. And that evening he went into his bed and he just started kind of crying, and I was like, Julio, what's wrong? What's going on, man? He could like barely get it out, and then he says, do you think I was showing off?
He's so
sort
small.
of imagining, he was like 3, and he's like sort of imagining, like, I might have hurt people, like I might have been just having fun and enjoying myself and been like hurting people this whole night and not even realizing it. we kind of talked about, like, I made a rule, being a good behavior analyst, good social skills trainer. I said, like, well, I think the rule is, if you look around and it looks like the more fun you have, the more fun other people are having, then you're just the life of the party. If the more fun you have, the less fun other people have, then you're showing off. But I always think about that in the example of kind of how even this 3-year-old who was like having such an awesome night, could kind of crawl into bed and wonder, like, have I messed something up? Have I hurt somebody? So yeah, it was that, really. It was, at the time Julia wasn't born yet, but I did have this little Hannah, this little kid that I was sort of watching navigate the world, and watching how easily, like, despite all of my attempts to make everything super safe and super engaging, how easy it was for her to kind of fall into her little bitty version of suffering, and really wanting to make the world a safe and perfect place for her, and recognizing that wasn't possible. I started, so at that time I had actually been pursued by my professor with behaviorism. He was sort of like hot behind me. This was Dr. David Greenway, initially, who was a peer of the professor who gave me the ACT book. They were both students of Dr. Mike Dewar at University in New Mexico. And Dr. Greenway, had been trying to convince me that behavior analysis was the perspective for me. And what I used to say about behavior analysis is that it sounded like just a bunch of smart people getting together and trying to decide how many things they could talk about in as few terms as possible.
So, I definitely get that.
And he would sort of laugh and go, like, yes, what's bad about that? But I felt like there was a richness missing, and there was something kind of lacking there. I didn't really get the purpose of that, the idea that there's the elegance in that perspective is not just to have fun, it's not just a fun game for no reason, that the elegance of that perspective is actually that it's actionable, that if we can sort of, see behavior and then see the cause of behavior outside of the stream, in the context, in the situation, in the environment, in things that we can then manipulate, then, basically people's repertoires, people's behavior that they have access to is only limited by the resources that we can provide them. I didn't get that right away. I didn't get that until I started actually reading the ACT book. So first it was just reading it, deciding. I was just at that time, at the time that I kind of finished it and picked it, I had been rejected for clinical PhD programs.
I bet they really regret that now, once they've seen the career that you've had since.
Who knows? I actually have some funny conversations with people that I'm like, I applied to your program. Like, did you? But I really didn't know. It was before, so the first time that I applied was before I had discovered behaviorism. It was before I had discovered ACT even, or I was just starting to get into it. But I just really didn't know. Like, I knew that I cared about, I wanted to help people, but they tell you that's not enough. Everybody wants to help people. You need some better reasons than that. I wasn't sure that I was going to be, I knew that I was interested in research. I wanted to be a clinician. I was really compelled, by suffering. I really love the idea of helping people to kind of connect with themselves and connect with their feelings. I knew that I was interested in eating disorders and body image. That was something that, especially I think being a woman and being in theater and being judged on appearance so frequently, that was something that felt very salient to me as a way of suffering that I could really connect with personally. But I really didn't have a perspective, I think. And so I kind of just applied broadly. And when people asked me about what I cared about, or what I wanted to do, or what kind of research I was interested in, I really didn't have a lens at that time. So, the ACT book first gave me a way of kind of knitting together my broader interests and I think just kind of emotional, being emotionally compelled by human suffering, the stuff that I think of more as my acting interests. it kind of allowed me to knit that together with my scientific interests. Right about that time, so I was applying out for the second time, feeling very sorry for myself,
Yeah.
and deciding that I was going to put all my eggs in this axe basket. And Dave, being very sneaky, Dr. Greenway, Dave decided to put me working in ABA. So I started working with Dr. Meeta Patel doing ABA. Meanwhile, I've got my ACT book, and Dr. Rick Perkins, who gave me the ACT book, is kind of helping me to piece that together, with my behaviorist understanding. And I'll never forget my first kind of home program that I worked in as an ABA therapist. There was he was the same age as my child. So I walked in, and of course I've got this child that's, not just typically developing. She was very, very verbal and very, very emotional. So I've got her, and it was just me and her. So we talked all the time. She had tons of stimulation. So, I've got her at home, and then I walk in to interview, and I'm going to meet the child and stuff to see if I get the job. And I walked in and immediately started doing all of the things that I did with, kids like Hannah and like her friends that she played with at school. And he sort of looked right through me and like turned around and like walked in the other room. And I was sort of really kind of shocked and kind of almost like afraid, like, wow, I think I'm in way over my head here. I don't know how I can help if none of my tricks work. He doesn't want anything from me. And I didn't really understand the job. And what I knew about behaviorism was basically from, my psychology undergrad classes.
Same myself.
And just from what, Dave had told me and was trying to convince me of. But I ended up, I think they left me in the room with him for a little while and kind of watched. They had cameras in the therapy room. And I sort of just started trying things, like sort of like put now what I would call like reinforcer sampling. Little toys and like seeing and kind of using different verbal directions and seeing what I could kind of get him to do and seeing what got his attention. And by the time we finished with the interview, I really, really wanted the job. And I got it. And it was the most gratifying work, that I had ever done. It was like raising a child, but in like slow motion. And I don't, obviously therapists aren't parents, and there's all kind of other stuff that goes into that. But the extent to which I could watch his repertoire just kind of unfold, and how strategically we had to be, and how I'd accidentally teach him, I make all kind of strange faces and move my hands and make weird verbal noises all the time. So I would like teach him to make weird noises by accident. I'd drop something and go like, woo-hoo, and then he'd like, mimic me. And then I'd go, oh man, I have to teach him to not do that. That's really weird. But sort of, just watching him kind of unfold as, a child, and then eventually a young man. And once he started speaking, it was just incredibly gratifying, incredibly moving, very quickly, within the first month of doing that work. So, I had Rick Perkins teaching me about acceptance and commitment therapy. I had Dave Greenway teaching me about the conceptual stuff having to do with behavior analysis. I had this beautiful little girl that was making the world feel meaningful to me in like an entirely different way since my brother died. And I had this client that I was like able to participate in his life in this incredibly intimate way and grow him, and really grow his world is how I thought about it. Like when I met him, his world was like tiny. Like the things that mattered were like 3 different toys that he liked, 1 cartoon, 2 things that he would eat, his mom.
I can fully understand.
And what we got to do is we got to just like grow his world, like make it huge, really, and really, really appreciate, what that means, like how learning happens and how things become meaningful and how meaningful things can become. It was incredibly gratifying work. So all of that together, by the time it was time to kind of interview and really solidify our applications, I felt really strongly that I wanted to do a degree in clinical psychology, that I wanted to do it in ACT. My biggest concern was that I would be a terrible clinician because I talk so much.
The client just comes, they're just coming to listen.
Exactly. They're going to come in and I'm just going to be like, blah, 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 and I'm going to interrupt them and I'm going to be terrible. And, you know, I think Dave and Rick both told me something like, well, I mean, is that what you do with, you know, your client? Is that what you do with him? Like, no, you like watch and you try something. You tell me all the time, like how you'll discover things that he can do and you'll put two things together to make him do a brand new thing. You know, it's going to be just like that, except with words, you know, except talking. And so that's when like RFT started to become really important, and I didn't really understand why or how, but I had this sense, I think, from the beginning that what I can do in the therapy room, if I do well, if I thrive, that what I would do in the therapy room would be just like what I do with this kiddo, you know, except there I'm using mostly things, you know, mostly physical objects and mostly kind of physically changing his world and making it meaningful in that way. And with my talking clients, that I'll be mostly staying in one place, but using words to make their world meaningful. And so, you know, I applied to a bunch of programs, and when I left the interview, here we have, you know, we go to lots of interviews. Well, if we're lucky, first time I didn't go to lots of interviews. The second time I did. We go to lots of interviews, and they're typically a whole weekend. And we had driven up to Oxford, Mississippi, from where I'm from, Lafayette, Louisiana, and where I've come back to. And it's about a 6-hour drive. And when I was driving home, I was just crying and crying and crying because I felt so comfortable there.
That's right. Sounds amazing.
I felt like it was just such a place that I could grow, a place that my world could become bigger and more meaningful. I loved Kelly Wilson, who ended up being my mentor. Alan Gross was the director of clinical training there. His blues band played like at our interview weekend. He was so kind, and the students were just supportive of one another. A lot of the programs that I went to, people were you could just feel the competition and the judgment and the criticism amongst faculty or amongst students. And I just wasn't interested in that environment. So going to Ole Miss was like, you know, I'm sobbing and I'm talking to someone at the time and they're saying like, why are you crying? Was it that bad? And I was like, no, it was wonderful. I didn't want it this bad. I wanted to just want a PhD. I didn't want a particular offer. But then I got to spend 5 years. I ended up getting an offer. And I accepted it right away. And I spent 5 years in that program, in the doctoral program.
It's been an incredibly successful program, though. I mean, like it's just very collegial, just to see where everyone's gone, and just the kind of things they're doing, and the breadth of the work is really amazing. Like it's very hard to pin anyone down and say, if you came from Ole Miss, this is what you do for your career.
No, and I think Kelly's lab in particular, and I have lots of colleagues that I really deeply respect there, but Kelly, we not only had Kelly, but you might know Dr. Kate Kellum. And so Kate had also overlapped with Kelly at UNR and had studied with Dr. Linda Hayes. So we got Kelly, who of course gave us lots of behavioral theory, lots of RFT, lots of ACT. You know, he was our primary clinical supervisor. We also got Kate, bringing in, you know, Kate worked in the Office of Research, so bringing in more broad, like we got to be pragmatic about this stuff. You know, the best intervention is the one that the best behavior plan is the one that the client's going to actually do. You know, the best intervention is the one that works. It doesn't matter what the research says. And bringing in the interbehavioral perspective. So it was it was a really, and beyond that, like beyond those perspectives, the kind of ACT perspective on clinical work and on, interventions and suffering at the clinical level, RFT for kind of understanding and analyzing verbal behavior and guiding some of our research. And then, behavioral stuff is kind of underlying all that, behavior analysis is underlying all that. What we did there, like the kinds of things that we studied were really up to us. Like we got to pick the phenomenon. So instead of being organized by, this is an anxiety lab, or this is a language lab or whatever, we got to do whatever we valued, like whatever our heart was in. In fact, that's one of the things, Ian, that I've always, admired about your program of research, is that it's like, hugely diverse in terms of kind of content, but from this, the thing that organizes the program is this really kind of consistent, contextual perspective.
Well, thanks for that. It sounds, sometimes I think it's a bit like Willy Wonka's chocolate factory at times, but the idea is just some crazy ideas. Some of them work, some will land, but some of them, it's probably better not said what happens to some of them. But thank you for that. But it's something. But yeah, but right, there is always there is a method to the madness behind it all. That's it. And could you, so you've written, is it now 3 books on acceptance and commitment therapy and eating disorders? So you've got, with Troy Dufresne, so you've got living with your body and other things that you hate, working from acceptance and commitment therapy. And you've also written with Kelly Wilson, who you've met in acceptance and commitment therapy for eating disorders. And you've also got one, is it specifically for bulimia and the mindfulness and acceptance workbook? Could you explain a little bit about what acceptance commitment therapy is in the context of eating disorders and what you might do with a client?
Sure. So, I think first, the thing that kind of stands out for us most with eating disorders or body image, really, and we can kind of take both. First with eating disorders, the thing that we see that feels sort of upsetting and that certainly has the biggest practical impacts is the eating behavior. So that disruption, either, in eating patterns, either kind of lots of restriction involving kind of purging behaviors or any kind of compensatory behaviors, excessive exercise or so forth. Like that's really what stands out, and that's really what sort of people see at first glance. The way that I think about it, though, is really in terms of that this is a broad kind of way of coping with a whole range of struggles. If we think developmentally, like oftentimes this starts with kind of body image or thinness concerns, appearance related concerns. But very quickly, it kind of takes on a life of its own. So very quickly, all, like, for example, all things might start to make me feel fat. So if initially it might be my clothing feeling tight, or me seeing myself in the mirror and noticing like an extra bulge or, something like that. But eventually, like if I kind of practice responding to that enough and organizing my life around that, I feel fat, so I'm going to skip a meal, or I feel fat, so I'm going to have an extra, hour on the treadmill, or the more that I organize my life around that, kind of the more that my life narrows, including my understanding of my own feelings. So, I fail a test and I can't go back in time and study the test. I can't, maybe I don't have the skills to go talk to the teacher and see if I can do remediation. So I almost start to experience that then as like fat. I fail a test, I feel fat, and I know what to do about fatness. I can go to the gym, or I can skip a meal, or I can take a diet pill, or I can, obsess and look at thin images on the internet. It starts to kind of take on this kind of self-sustaining, process where anything that is difficult, anything that produces like an aversive, anything that starts making me want to run, fight, and hide, that I experience as related to my body and related to eating and related to food. And that's adaptive, even though it's maladaptive and quite dangerous. It's adaptive because I have all of these things that I do about it. So then I have all these behaviors I can engage in that give me relief. There are these very precise ways of running, fighting, or hiding from any experience that's painful and difficult. And over time, my life gets more and more narrow. It starts to narrow more and more and more around, eating and body stuff. My experiences start to narrow. My behaviors start to narrow, and probably, like, practically speaking, I stop doing as many things, and those things stop functioning as broadly. They stop feeling as broad. I stop contacting them in as rich a way. So, if we kind of take that as like my understanding of eating disorders, there's actually kind of an ACT perspective, right, built in there. What the way that ACT sees struggling is that psychological struggling is about psychological inflexibility. It's about rigidity and narrowness. From a behavioral perspective, I think of learning that there are two ways that we can be learning, or two ways that we can be interacting with our environment at any one time. We're always learning, right? In one way, it's about running, fighting, or hiding, and that behavior tends to be really narrow. And we're doing that, our world gets really small and tight. The things that can influence us become really rigid and minimal and limited, and our behavior becomes really rigid and limited. And the only thing that we really are good at learning under those circumstances is new ways to get away, new ways to run, fight, or hide. That might be making ourselves throw up, taking a diet pill, staying at the gym, but also it's not only related to eating disorders. It could be, having a drink. It could be pulling our hair out, whatever kind of mode, or whatever kind of shape that mode takes for us. But then on the other hand, we have this other way of learning and of being in the world and of interacting in the world. And we call that like appetitive control, or seeing, exploring, engaging kind of behavior. And that behavior tends to be the opposite. It tends to be really broad and really rich and really flexible and sensitive to lots of aspects of the environment. So the world gets big and our behavior gets big. It can easily kind of change direction and pick back up and be sensitive to something else and then something else. Instead of running, fighting, or hiding, kind of seeing, exploring, engaging. And we can think of behavior as being kind of on a continuum at any one time. There's always some scary stuff that we're trying to run from and some juicy stuff that we're trying to aim towards. So we can imagine the repertoire, our behavior at any one moment, kind of on a continuum from psychologically inflexible, and that might be that aversive control, that running, fighting, or hiding, all the way to psychologically flexible, which we might think of as appetitive control, or that seeing, exploring, and engaging. So what I described with respect to eating disorders is really a repertoire becoming more and more and more dominated by aversive control, and those aversives being very particular to the body and to dangerous foods. And we might have other things that go with that, but that the whole world kind of gets sucked up into those categories, and those are kind of the only thing that matters. Other things might come up and we don't respond to it well. So what ACT does is we try to move people from psychological inflexibility to psychological flexibility, and we do that really by creating situations that produce some running, fighting, or hiding. So allowing for contact with those things that make us, run, fight, or hide, that get us kind of stuck and rigid, but then gradually adding new things in a very careful way, new things to that situation, that circumstance that produces running, fighting, or hiding, that introduce new skills, so that, evoke and then reinforce, support kind of new learning that allows for appetitive learning, even in the context of those aversive things that start to broaden out the repertoire bit by bit. So if I have a client that who is feeling quite stuck maybe in their body in that moment, and maybe that feels like or looks like lots of anxiety, maybe they're speaking very quickly, maybe they're struggling to pay attention. If in that moment we can think of like, there they are running, fighting, or hiding, the context is pulling for that. If in that moment I can help them to, for example, draw a nice full breath, and to pay attention to what that breath feels like in their body, right? Their body is still salient, and that's really dangerous and scary thing. But if they could breathe and feel that breath in their body, you can imagine, like, I've broadened out the repertoire just a little bit, And then if I can reinforce that, and then if they can, take a moment and have sympathy for themselves. Maybe I've reinforced that. And if they can think about and remember a story that their mother used to read them when they were 10, then, and I reinforce that. If each of those things are happening in the presence of the scary stuff, even with their body being like it is, they're no thinner than they were 10 minutes ago. And even with, the situation still pulling for the anxiety around the body, maybe with every new behavior that we teach, the repertoire is becoming more flexible. There's more options, right?
Exactly.
There's less, their repertoire is less dominated by aversive control. And indeed, that's what Skinner used to call freedom, that freedom, what we mean when we say free will, what we're actually naming is freedom from aversive control. We're having the experience that we have when our repertoire isn't dominated by the need to run, fight, or hide, but where we have options, we have behaviors that are possible in that circumstance. So in the same way I talked about, that client, I keep almost saying his name, but my first ABA client, and that his world was very, very small. It wasn't small because of aversive control, it was small because of his particular learning history and how that interacted with his neurodiversity, the neurological insults he had experienced. But if we sort of think of that as like what we were doing is just training like one little behavior at a time and gradually broadening out his repertoire and then putting him in challenging situations and broadening out his repertoire there, it's not that different from when I'm applying ACT with my clients. And it's not that different from what I try to do in the book, in Living with Your Body or in the eating disorder self-help books, which is to like present the hard thing, help the person to be with the hard thing, and then teach just one new thing they could do there. And then maybe a second new thing they could do there and a third new thing.
So one of the things that's really interesting, so what you're saying is like if you focus too much on the cognitions on the person's thought in themselves, you're not going to get very far, because like if a person comes to you, say a girl who's 16 and she believes that she's fat, even though clearly in front of you as she's not at all fat, and like she could be even dangerously thin, like so you're saying pretty much nothing you can really do will change that cognition itself. So what you have to do for successful therapy is to work on expanding her world, expanding her options, expanding her choices in certain domains.
No, that's a great point. We see, if you think of all of the behaviors that we're engaging in any one moment, we tend to think that the thought part, like the thinking part of behavior, is really important and fundamental and foundational for everything else that we do. We tend to think that that's sort of the explanation of everything else we do. From a behavioral perspective, we call that mentalism, because we're saying like, no, like the world is shaping both the thinking and the whole rest of the behavior. So if I have somebody come in and what's really obvious to me is them saying I am fat, and I look at their body and there's just no objective world in which they are actually fat, our purpose or my purpose in ACT would not be to get rid of the thought I am fat. My job would be put her in situations that pull for that thought I am fat, and that pull for all the other problematic behaviors that she has there. And build out her repertoire to where when she's in those situations, she might still have the thought I'm fat, but she can also, have different thoughts. She can also, feed herself in a way that's consistent with her dietary plan. She can also take a walk. She can also listen to some music, that her whole repertoire can be at hand then. So in I think the implications for somebody that might be struggling or know somebody who struggles in that way, are like, let's not we don't have to be convinced that our mind kind of drives the bus. We can notice our thoughts and be aware of them without giving them any agency. I think often like being able to think of ourselves in a moment of struggle in the same way that you and I are thinking about, a pretend client in a moment of struggle, and say, what is it that we'd want her to be able to do there? Wouldn't it be cool if she could breathe? And wouldn't it be cool if she could think of something she cares about? And wouldn't it be cool if she could have a precious memory? Like, can we think of ourselves like that? Can we say, like, in a moment when I get most stuck and most vulnerable, what would I want to give myself as one new behavior I could do there?
That's really interesting putting So is it fighting kind of a losing, not like say losing battles and negative? So you do great work in therapy, and you've set up this new contingency, and they're doing something new. But are you constantly battling against them looking at their own smartphone and them evaluating them and judging themselves against what they see as the supposed perfect body. I know we're kind of leaning
Yeah.
towards females here, but it would apply to males as well.
Sure. No, absolutely. You know, I think that's a really yeah, it's a really big challenge, is that we are in this very particular context, and you know, your point being that like everywhere else in the world, the messages that they might be getting are highlighting those aversives, or
Yeah,
saying, you know, compare yourself, this is your worth. It's your job to be pretty and not effortful about it. um, but you know what, so really that's the challenge for me. Is it's funny because it's kind of counterintuitive from how a lot of people think about it. It's to make therapy not necessarily a safe space, but a healing space,
yeah,
which means that like anything that happens when they, you know, look at the picture of the model, or you know, are faced with media or watching movies or scrolling Facebook or Instagram or whatever, anything that comes up there, it's my job to really bring that up in the room. It's
okay,
my job to make our therapy context one where all of the hard stuff can come up. So it is a challenge, but if we're working, I think if we're working behaviorally, you know, then we're giving them direct practice with contexts that evoke that, by making therapy a context that
yeah,
brings that up. And you know, we get to pick together, and they get to pick, you know, primarily what is the response that they would want to have, you know, in that world. Like, is it that, you know, is there a limiting of that kind of contact with that kind of media that they want? Like, does that make sense for them?
yeah,
Is there some juicy stuff there that's important to them that they don't want to limit that? Instead, they want to build their repertoire to accommodate it. You know, and people make all sorts of choices. Sometimes initially they might limit their contact with stuff like that, in the same way that if I'm trying to stop drinking, I probably don't need to spend every night at the bar, at least
yeah,
at first.
yeah, yeah,
But it might be really important to me culturally, if I'm from Louisiana or if I'm Irish,
yeah,
it
yeah.
might be really
Okay.
important to me,
Yeah,
that I can go into a pub, you
yeah,
know, that might be really significant. And just limiting pubs is not going to build my repertoire. It might give me some relief where I can
yeah,
build my repertoire, but I would want to build it enough that I could go back to the pub, that I could,
yeah.
you know,
I've
be
literally just written that very point in a paper. But
like,
it is that issue. Like, it's very
yeah,
difficult when you're fighting against cultural issues and they're getting the social reinforcement from the friends at the bars, because that's what their only
absolutely.
network opportunity for socializing. Then it's hard to give up the drinking, even though you might have been doing some really good work in the therapy sessions.
Absolutely. Well, and that means that in my, you know, in my therapy, I think the other thing it brings up for me is that I've got to not only bring up the hard stuff, but I've got to make sure that I'm not the only reinforcer there,
Yeah,
that it's not just
exactly.
me going, good job, great job, you did a good job. You know, in ACT, we really emphasize values. So, you know, it's my job to bring in both the scary stuff that makes running, fighting, or hiding,
Yeah,
and like the meaningful stuff, the stuff that's going to be, you know, sometimes the stuff that's going to be pleasurable, sometimes the stuff that's just going to be really significant and personally
yeah,
important to the person, to where everything hard that we do is in service of that. You know,
yeah,
what would you want to be actively valuing in the moment that you feel
yeah,
really fat, or
yeah,
that you feel, you know, or that you feel really lonely, or that you're really having terrible urges to drink?
yeah,
You know, what is the action that would be meaningful? You know, what
yeah.
would you want to be acting in service of?
Thanks. That's really interesting. I'm just going to move on now to you're a former editor in chief of the Journal of Contextual Behavioral Science, and you're a huge champion for women in science. So I see you as a success story. So you're a single mom who battled against all the odds, and now you're an incredibly successful scientist and um, clinician. So you're combining lots of different roles. And for those who might understand, so you are a professor at a university, but you also have your own private practice as
Mhm.
well. But and on top of that, you opted to be editor in chief of a major journal. Can you just describe some of your experiences around that, and also any tips or messages that you might have for women in science who might be
Yeah.
finding it difficult, or the contingencies are slightly different for them than they might be for men, for example?
For sure. You know, I think the thing that stands out most in terms of that experience was just really understanding all of the human decisions that are involved in publishing,
Yeah.
in the review process, all of the very human choices that are made. I think so often as a new academic, you feel like there's like a choir of angels that's deciding whether or not you're worthy, and these sort of perfect beings that are deciding whether or not you deserve to be a scientist. And for me, I think seeing all of those working parts was so eye-opening. Even at that time, I had been publishing and serving as an associate editor and a reviewer for some time, but really seeing all of the pieces, that these are just humans trying to do good work. That's all they are.
Even reviewer too.
Even reviewer too is just trying to do good work. Maybe they're running, fighting, or hiding if they're particularly nasty. So really, I've as a result, I think really encouraged my students to join me in reviewing. I've tried to give lots of presentations on, okay, do you know what happens when you send that paper? I was stunned to find that there were, maybe people with brand new PhDs, but still people that had finished their degree that really didn't know all of what happened once they hit submit. They knew the part that they saw, but really weren't sure what all the pieces were. So just, one thing that I think, and this does link to the ultimate question, is just transparency. So, one thing that I've tried to do is provide lots of transparency. I think one thing that comes with privilege, whether it's, male privilege or white privilege or economic privilege or educational privilege, language privilege, one thing that comes with privilege is that you take transparency for granted, that you're well socialized and know how things work, and just how much that can inform, even if it doesn't feel strategic, how much that can inform what you do or say, the choices that you make. The other thing that I would say, like just in terms of kind of tips or strategies, has been that my son is practicing piano.
That's a big bonus. I'm happy for that soundtrack. It's a really excellent soundtrack.
One thing that Kelly taught me, and that I think that Ole Miss was a good place for anyway, and that my loving professors here at UL, Drs. Perkins and Greenway, they really emphasized making spaces and creating contingencies for ourselves where we get to have contact with our values. Kelly, by helping us to pick topics that we were interested in, Rick and Dave by making sure and positioning me in experiences that they knew were going to compel and touch me, and my DCT at Ole Miss used to end every single email by saying, "Have fun, boys and girls."
That's nice. Yeah.
And so this stuff is not sustainable. If it's running, fighting, or hiding, like, it's not sustainable. I'm doing all the things that I do, but my bigged rule is like, do the thing that makes the most like fun and meaning for the most people for the longest amount of time. And don't be scared to create spaces, even if the contingencies that are established for you, even if the system doesn't make contingencies that support that for you, make them for yourself, because otherwise it's not worth it. There's just nothing else that's worth it. So find social relationships that are going to help you to do valued work. Pick topics that you care about. Pick strategies that are fun. If your lab isn't fun anymore, then pick more fun stuff to do. Make your life as fun and meaningful as you can. And I really think I offer that not as like a third thing on the to-do list, as like the first thing that organizes your to-do list from there. So.
And that's excellent advice. I've taken a lot from that. But I think it's something that nearly anyone could apply. But I think that you're a really great example and a really great role model, Emily. So I think that's something that I see you bring to every aspect that I know you. And you're very passionate. If you see you at a conference, most people are kind of worked up about their one presentation for an entire 4-day conference. You might have 16 presentations and 5 workshops, and you're leading the karaoke session at the end of the evening always. So, but I think it's something that you always seem to bring a purpose to everything. Like as you said, you're very value driven in what in all your actions. There's a reason, but it's not. But it's a very healthy reason. It's always like something that really really positive. And I think so. That's something that I think you're an excellent role model for all young scientists, especially female scientists, but all scientists. I think so. But thank you for joining us today. That was a really, I thought there was some really excellent in the insights there, and things that you can really bring to both academia and to the therapy room, especially for something as complex as eating disorders. Because when you're in those clients, a lot of it just seems obvious to say, well, you're clearly not fat, or you're clearly not too thin. It seems obvious, and yet they've been living this for years and years and years. So the solutions are not simple, but what you've given us there are really practical ways to go about actually expanding their world, and so trying to loosen their rigid behaviors so that they don't always have to make that their go-to response all the time. They don't always have to eat that. They don't always have to go drinking that bottle of wine, or they don't always have to eat that tub of ice cream if they had a really, really bad day. So we don't always have to have that exact same rigid response or that same kind of thought process. So that was really interesting. But I just wanted to thank you for joining us today. And I'd like to dedicate this episode to, we really sadly lost Leanne Harris fairly recently over Christmas. And I talked to her quite a bit over some ACBS, Association for Contextual Behavioral Science type work. So she was always promoting women in science, and she was a huge fan of yours. So I'd like to dedicate today's session to Leanne. And but thank you, Emily, and I hope you have a lovely rest of the day, and thank you for your time.
You too.
Bye, Emily.
Bye.
Bye.